Hello, thank you for joining us today. My name is Kristin Watson. I'm an associate professor at the University of Maryland School of Pharmacy. As part of our Under Pressure, a focus series on hypertension, I will be talking about the patient assessment piece. In this program, we are going to be talking about what assessment strategies should be taken when determining the etiology of hypertension, as well as identifying a patient's risk factors for hypertension and their cardiovascular risk factors so that we can appropriately manage the patient and select the appropriate treatment option. As we know, primary or essential hypertension is the most common cause of hypertension among our patients. This is when there is no identifiable cause for the patient's hypertension. This primary or essential hypertension gradually occurs over time. We also have known secondary causes of hypertension. It's important to evaluate our patients for these secondary causes, especially when we see patients who have treatment-resistant hypertension. These secondary causes, by treating them, can potentially improve the control of a patient's blood pressure. Causes of secondary hypertension can include the white coat phenomenon. As many of us are familiar with, this is when a patient presents to a clinic visit and their blood pressure is higher than what it is in their home setting. And that is because the blood pressure gets elevated, potentially due to stress, being in the office visit. This is because of this white coat phenomenon. This has been a focus of using ambulatory care blood pressure assessments when managing and treating hypertension to evaluate what the patient's blood pressure is in their home setting when they're in that more relaxed environment as opposed to coming in clinic. That ambulatory care blood pressure monitoring also give you more values than those isolated values when a patient presents to clinic. Other causes of secondary hypertension include chronic kidney disease, renal artery stenosis, obstructive sleep apnea, primary aldosteronism, and then other causes, more rare causes such as Cushing syndrome, a pheochromocytoma, and aortic coarctation. We also need to look for potential causes of drug-induced hypertension. So as part of any assessment that we're doing with a patient, we should be doing a complete medication history, including the use of prescription medications, over-the-counter medications, as well as herbal products and illicit substances. By doing this, we can potentially identify medications that may be leading to an increase in the patient's blood pressure. It's important to note, as we will discuss, some of these medications, while they may lead to drug-induced hypertension, we may not be able to take those medications off of the patient's profile and may need to treat through that hypertension. One example that we'll discuss is the use of immunosuppressive therapy, such as cyclosporin and tacrolimus. The patient can be on those medications post a transplant, and if that medication is part of their regimen, we would not necessarily want to change the patient's immunosuppression regimen. Rather, we would want to go about treating the hypertension. So we can think of medications. So going through their complete medication regimen, I've listed here several medications that can lead to drug-induced hypertension. This includes things such as oral contraceptive pills. Women who are over 35 have a history of family members developing hypertension on oral contraceptive therapy are at increased risk for this. And that's why it's important in women who are on oral contraceptive pills that they have their blood pressure checked routinely to evaluate for potential hypertension. Our mineralocorticoids and our corticosteroids can also lead to increases in blood pressure, as well as use of medications such as phenylephrine and epinephrine. Antidepressants, we know that venlafaxine and our tricyclic antidepressants can increase the blood pressure. Again, if that blood pressure increases occurs, we need to take a look at their medication, their psychiatric history, before determining what's the best course of action to take with those medications. As I mentioned before, immunosuppression therapies such as cyclosporin and tacrolimus can lead to elevations in blood pressure. With this, like medication such as this, again, you may not have to be able to remove the offending cause, but you may need to go ahead and treat through that hypertension. But identifying that as a potential cause is important to do. We also know that illicit substances such as cocaine and amphetamines, can lead to hypertension in patients. So making sure we have a clear sense of what substances our patients are using. And then also some herbal products have been associated with the development of drug-induced hypertension. So making sure we get a clear sense of supplements that our patients are using. I always think it's important when asking a patient about herbal products is to give them a list of names of herbal products that they may potentially be using to find out, so they have a sense of what you're doing. So asking them, do you take things such as St. John's wort or licorice, so that they have a sense of what herbal products are and which ones may potentially be a problem. Part of our workup for the management of hypertension includes the assessment of cardiovascular risk factors. It's important to identify these risk factors as some of them may be modifiable, so we can use this to manage and potentially treat these risk factors to lower a patient's overall risk of cardiovascular disease, in addition to managing their hypertension. We can also identify the appropriate blood pressure goal for a patient, as well as the appropriate selection of treatment to manage their hypertension. Some of our non-modifiable risk factors for patients include a patient's age and a family history. We know that a patient who has a family history of premature cardiovascular disease is going to be at higher risk of developing a cardiovascular event as opposed to somebody without that premature risk. We know that obesity is a risk factor for the development of hypertension, as well as a risk factor for the development of cardiovascular disease. But we also do know that weight loss is a potential treatment option for hypertension in those patients who are obese. So by addressing this with our patient and potentially setting weight loss goals, we can potentially help lower their cardiovascular risk and potentially also help lower their blood pressure over time. We also need to look at what's the patient's level of physical activity. Our patients who are physically inactive, we know that they are at a higher risk for cardiovascular disease. So incorporating an exercise regimen as part of a patient's management for hypertension, we could potentially help them lose weight and overall improve their health status. Tobacco use is also a known risk factor for cardiovascular disease. Regardless if we're seeing somebody for hypertension, for any other condition, we always want to ensure that we are assessing for the use of tobacco and making attempts to assist the patient and talking to them and how we can help them achieve smoking cessation. Renal disease is another risk factor. We know that renal disease can lead to the development of hypertension. And identifying renal disease as a risk factor is going to be very important as we're identifying the selection of treatment regimens for patients and what their blood pressure goal is going to be. Identifying and reviewing a patient's cholesterol panel may be of help. Looking at patients' risk factors and identifying if they qualify for an HMG-CoA reductase inhibitor or statin therapy is also beneficial and should be part of our workup. Patients who qualify based on risk factors for statin therapy, the use of that, in addition to controlling their hypertension, can help reduce their overall risk of heart attack or stroke. And then finally, it's important to also identify if a patient has diabetes. If they have not been screened for diabetes in the past, depending on the patient criteria, it would be important to have this screening occur. Again, the comorbid condition of diabetes is going to dictate which therapy that the patient may receive for the treatment of hypertension, as well as their potential blood pressure goal. When encountering a patient diagnosed with hypertension, we want to assess if they have already had any complications as a result of their hypertension. By doing this, again, can help us in determining the appropriate blood pressure goal for the patient and can also help us in determining which type of therapies we have available and would like to use for the patient. I think also identifying the presence of complications for hypertension, if one has been identified, it's important for us to use that as our counseling points as we are talking about the benefits of treatment of hypertension and how by treating and adequately controlling their blood pressure, we can lower the risk of recurrent events. So what are these complications that we think of? So we think of a patient with stroke. Have they had a stroke in the past or transient ischemic attack? Do patients have retinopathy? Ensuring that if the patients have not had an ocular exam recently, that we are setting them up to have that assessed. From a cardiac perspective, we want to assess patients to determine if they have known heart failure, have they had a myocardial infarction, or do they have established coronary artery disease. We want to make sure that patients, especially before beginning therapy, what is their renal function? So determining a Chem7 on patients will be very helpful. So determining what their baseline renal function is as we initiate therapy, because as we know, some of our therapies can have the potential to affect renal function. So it's good to have that baseline early on. And as discussed previously, we know that identifying a patient has chronic kidney disease, that's going to probably lead us to pick one medication over another as our first line therapy in many patients for the treatment of hypertension. And then, do patients have peripheral vascular disease? So again, a peripheral vascular disease or peripheral arterial disease being a complication of long-standing hypertension. So we want to make sure that we assess for this as part of our overall assessment of patients with hypertension. The following are credits for the images that you saw used in this presentation. Thank you for joining us today.